Hi, welcome to my today's classroom. Today I will be discussing about portal hypertension. Now, what is this portal hypertension? Whenever pressure in portal vein increases, that is known as portal hypertension. And this problem, portal hypertension, is a very serious matter. Whenever there is a portal hypertension, overall life of patient is disturbed in portal hypertension. So portal hypertension, once detected, it should be treated in a proper way. Now this portal hypertension is divided into two categories. One, because of extrahepatic involvement, that is diseases which affect extrahepatic part of portal system. If disease is affecting intrahepatic part of the portal system, then it is known as intrahepatic portal hypertension. So we classify portal hypertension into two varieties. One is extrahepatic and other one is intrahepatic. Intrahepatic is further classified into pre-sinusoidal and sinusoidal variety of portal hypertension. Similarly, extrahepatic variety is again of two types, prehepatic and posthepatic. So this whole portal system is divided into hepatic, prehepatic and posthepatic. That is intrahepatic, prehepatic and posthepatic. So there are various causes of this portal hypertension. Not only liver diseases, but apart from liver diseases, there are many other causes of portal hypertension. In intrahepatic portal hypertension, usually the pre-sinusoidal variety of portal hypertension is because of schistosomiasis. It is also seen in early primary biliary cirrhosis. Apart from this, chronic hepatitis can cause this type of portal hypertension, pre-sinusoidal variety of portal hypertension. Even cirrhosis can cause pre-sinusoidal variety of portal hypertension. Certain toxins like vinyl chloride and many other toxins affect this pre-sinusoidal part of liver and cause this portal hypertension. Sinusoidal variety of portal hypertension is usually seen, sinusoidal intrahepatic is usually seen in cirrhosis. Any type of cirrhosis can cause sinusoidal portal hypertension. Apart from this, extensive hepatitis can cause this type of portal hypertension. Usually alcoholic hepatitis can cause this type of portal hypertension. Vitamin A intoxication can produce this type of portal hypertension. Post-sinusoidal variety of portal hypertension is because of usually veno-occlusive diseases. Veno-occlusive diseases usually produce this type of portal hypertension. Prehepatic portal hypertension and posthepatic portal hypertension both are usually because of involvement of veins. They are not related to liver. Prehepatic portal hypertension is usually seen in idiopathic tropical splenomegaly syndrome. Apart from this, splenic vein thrombosis can produce this prehepatic variety of portal hypertension. Extrahepatic portal vein thrombosis can also produce this prehepatic variety of portal hypertension. So anatomy of this portal system must be clear in mind. If it is not clear in mind, then you cannot understand the various regions where there is obstruction, as a result of which portal hypertension develops. Posterior post-hepatic portal hypertension is because of involvement of inferior vena cava, portal vein, that is portal vein thrombosis, Budd-Chiari syndrome. In inferior vena cava, if there are webs, there is thrombosis, then again it may lead to portal hypertension. Apart from this, whenever in right atria there is high pressure because of valvular heart disease or any problem in heart, whenever there is increase in pressure in right atria, again portal pressure is increased. Now one by one I will talk about different varieties of portal hypertension. First, I will talk about extrahepatic variety of portal hypertension. Now this extrahepatic variety of portal hypertension is usually seen in extrahepatic part of portal system. The obstruction occur at any point right from the umbilicus to the hepatic area. Now, etiology of this range from spleen, umbilical vein, splenic vein, and extrahepatic part. Anywhere if there is obstruction, it will lead to portal hypertension. Whenever there is umbilical infection, this umbilical infection may extend from umbilical vein. Usually this type is seen in neonates. This may extend from umbilical vein into portal system and may produce portal vein thrombosis and later on portal hypertension. Sometimes in neonates, because of severe dehydration, there is portal vein thrombosis in the extrahepatic part of portal system. There is thrombosis, and again this will lead to portal hypertension. Portal hypertension can also occur in abdominal injuries during accidents, steering injury. It can cause portal hypertension. If a lady is consuming oral contraceptives for a long time, again it can cause extrahepatic portal vein thrombosis, and it may lead to portal hypertension. Similarly, in pancreatic carcinoma, sometimes there is invasion of pancreatic carcinoma in this area and it will produce portal vein thrombosis and it may develop portal hypertension. Similarly, in congenital abnormalities of portal vein, sometimes there is portal vein thrombosis in extrahepatic part of portal system and it will lead to portal hypertension. Portal vein thrombosis can also occur during pregnancy and in many disorders of coagulation. So like this, portal system is one of the very important part and its anatomy must be clear in mind. Without the clear anatomy, you cannot understand about the portal hypertension. Now, the clinical features of portal hypertension. In clinical features of portal hypertension, you can see that these patients, they usually present with hematemesis and upper GI bleeding. This upper GI bleeding is usually massive many times, and this massive bleeding is because of rupture of esophageal varices. And these varices, they rupture whenever pressure is very high. To release pressure, they get ruptured. So there is massive bleeding. Patient may present in shock. Patient will present with melena. But many a times the bleeding is slowly going on and it is very difficult to detect. And you can only detect with the help of examination of stool. You will get occult blood in the stool. You may not get clear-cut melena in these cases. So there is flank bleeding not present in many cases. So you will get occult blood and anemia in these patients. So upper GI bleeding is one of the symptom of portal hypertension. So portal vein hypertension, and it will, so if it's spleen, in these cases, if you examine the patient, you will get splenomegaly in portal hypertension, whether it is intrahepatic or extrahepatic. So liver is totally normal in these cases of extrahepatic portal hypertension. Liver examination is totally normal. Only you will get hypersplenism, you will get splenomegaly. On examination, you will get prominent abdominal veins. These abdominal veins are prominent over umbilicus. You will get radiating veins from the umbilicus. Liver is totally normal. You will not get anything in the liver. Later on, patients may develop encephalopathy, and this encephalopathy is because of shunting of blood. There is shunting of blood from portal to systemic area, systemic circulation, and because of this, there is encephalopathy. In these patients, there are hematological changes in the blood. There are hematological changes. There is thrombocytopenia, and this thrombocytopenia is because of hypersplenism. Patient may have anemia. Again, this anemia may be because of bleeding plus hypersplenism. Spleen will destroy red blood cells. Spleen will destroy platelets. So you will get thrombocytopenia and decreased RBC count. This will add to anemia. Thrombocytopenia will increase the bleeding tendency. So these are the hematological features of extrahepatic portal hypertension. Serum biochemistry, when you do, that is totally normal. Liver functions are totally normal in these cases. Prognosis overall in these cases depends on the underlying cause. You will have to treat the underlying cause. These patients, they usually present with massive bleeding. So whenever they present with hematemesis, melena, massive bleeding or in shock, you will have to treat these patients symptomatically. The first thing is to do is endoscopic examination, upper GI endoscopy. When you do the upper GI endoscopy, you can see the bleeding varices. Varices may bleed in esophagus, they may bleed in stomach, or they may even bleed in duodenum. It depends where the varices are present. So you can locate these varices by upper GI endoscopy. The first thing which you will have to treat in extrahepatic portal hypertension or any type of portal hypertension is to control upper GI bleeding and to treat the patient symptomatically. So first you will monitor the vitals, you will catheterize the patient, intravenous catheterization is done. Immediately you will maintain the blood perfusion by transfusing blood. Number 2, you will have to inject octreotide. So these are synthetic somatostatins. This octreotide is given in the dose of 100 micrograms straight intravenous in form of bolus, and then 50 microgram is given in form of infusion every hour with the help of infusion pump. And this octreotide is continued for about 5 days after the control of bleeding. It should not be stopped for 3 to 5 days after control of bleeding. 50 micrograms per hour it should be given. Apart from this, by the help of upper GI endoscope, if it is possible, you will have to do endoscopic variceal ligation with the help of endoscope. This is done on priority if the varices are visible. If bleeding is controlled with the help of octreotide, you do immediately upper GI endoscopy and ligate the bleeding varices. So first thing is you give blood infusion, then you blood transfusion. Then after blood transfusion, immediately simultaneously you start with octreotide, control bleeding with octreotide, and do esophageal variceal ligation. So this is the stepwise management of portal hypertension, any type of portal hypertension. Now, with the help of esophageal variceal ligation, even with the help of esophageal variceal ligation, if it is not controlled, bleeding is not controlled, then in that case, I usually advise for TIPS. That is, TIPS is a procedure in which through the jugulars, a catheter is passed down into the liver, and there the portosystemic shunting is done. With the help of TIPS, you can immediately lower down the portal pressure. So if it is not controlled with the help of octreotide, with the help of esophageal variceal ligation, I usually advise for TIPS. TIPS is the treatment to control the portal pressure. Prophylactically, you can give propranolol in the dose of 40 milligrams per day. This can control the portal hypertension up to some extent. But with the help of TIPS, you can control the portal pressure. In case of portal vein thrombosis, if portal vein thrombosis is detected earlier with the help of color Doppler study, then in those cases, you can start with anticoagulation therapy and prevent the further progression of thrombosis. In past, vasopressin was usually used in the cases of upper GI bleeding, but vasopressin had adverse effects on the coronary circulation. So because of that, nowadays vasopressin is not used. Previously, before the use of this esophageal ligation, sclerotherapy was done in these cases, but now this is also becoming obsolete because it many times produces complications like esophageal stricture formation, and many a times the sclerosing agent, it enters into the mediastinum and produce mediastinitis. So nowadays it is not used. Another cause of extrahepatic portal hypertension is splenic vein thrombosis. Now this splenic vein thrombosis, again, it can be caused by oral contraceptives if taken for a long time. It can be caused by any peritoneal sepsis. It can be caused by by oral contraceptives if consumed for a long time. Even steering injury can produce this splenic vein thrombosis. So these are the various causes of splenic vein thrombosis. Now in cases of splenic vein thrombosis, again they present with pain in left upper quadrant of stomach, and later on with splenomegaly and upper GI bleeding. So upper GI bleeding, whether any is due to this portal hypertension, is managed in the same way as the other causes of the portal hypertension. So in the same way you will manage this splenic vein thrombosis also. So in the next part, I will talk about intrahepatic variety of portal hypertension. Now this intrahepatic variety of portal hypertension, in this variety again you will get increased portal pressure and all features very similar to that of extrahepatic portal hypertension. And in this part again we classify into two types: pre-sinusoidal and sinusoidal variety of portal hypertension. Now the pre-sinusoidal variety of portal hypertension is usually seen intrahepatic variety. I am talking about intrahepatic variety inside the liver, pre-sinusoidal. So in the pre-sinusoidal area, sometimes in cystosomiasis, the parasites, it invades that area of portal vein, that area of sinusoids, and produces an inflammatory reaction, and as a result of that inflammatory reaction there is formation of thrombus inside and there is obstruction of the circulation, which leads to portal hypertension. In congenital hepatic fibrosis, sometimes this particular area is obstructed and it may cause portal hypertension. In myeloproliferative disorders, these are the disorders which are related to proliferation, abnormal proliferation of cells which are originating from bone marrow. So this variety is of leukemia, chronic leukemia, acute leukemia, any type of myeloproliferative disorder can cause this type of thrombosis in the pre-sinusoidal region, and it will lead to portal hypertension. Another condition is there which is known as systemic mastocytosis. In systemic mastocytosis, again there is portal hypertension, increased portal pressure. This is because of increased intrahepatic resistance due to infiltration of mast cells in that particular area, pre-sinusoidal area. In primary biliary cirrhosis, this is a connective tissue disorder. Again, in this primary biliary cirrhosis, sometimes there is increased pressure in the sinusoidal region, pre-sinusoidal region of the portal system, intrahepatic part of the portal system. This is because of autoimmune reaction in that particular area. So sometimes it may be the earliest feature of primary biliary cirrhosis. Sometimes injurious substances which are fibrogenic, they can produce toxins, hepatotoxins. They can produce pre-sinusoidal intrahepatic variety of portal hypertension. Even alcohol, vitamin A in excess, arsenic, these are all the substances which produce damage to the pre-sinusoidal region. Methotrexate, this can produce damage in the pre-sinusoidal region, as a result of which there is portal hypertension. So these are the various causes of portal hypertension in the pre-sinusoidal area. Now I will talk about hepatoportal sclerosis. Now what is this hepatoportal sclerosis? In hepatoportal sclerosis, again in the pre-sinusoidal region and sinusoidal region, a part of sinusoid and pre-sinusoidal region, that is sclerosed. This hepatoportal sclerosis is a disorder of unknown etiology. There may be extensive fibrosis. This fibrosis is of unknown etiology. It is said that sometimes it may be because of some connective tissue disorder, autoimmune disorder. So as it is a disorder of unknown etiology, it is an exclusion diagnosis. First of all, you will have to exclude other causes of fibrosis which are producing fibrosis in that area. If you have excluded all the other causes of fibrosis produced in that area, then only you can label it as a case of hepatoportal sclerosis. Whole of that that area of portal system is sclerosed. It is known as hepatoportal sclerosis. Again, presentation is in the same way. There is increased portal pressure, varices are formed in the GI tract, and there is bleeding from the GI tract. Management is also very similar. The only thing is that you will have to work on the etiological factors. You will have to exclude etiological factors one by one. Once you have excluded the etiological factors, then only you can say that it is hepatoportal sclerosis. Another variety is of the portal hypertension, pre-sinusoidal variety, is tropical splenomegaly syndrome. In tropical splenomegaly syndrome, in extrahepatic part and a part of intrahepatic part, pre-sinusoidal region is involved, and in these cases portal pressure is increased. Now again, in this tropical splenomegaly syndrome, usually you get history. This is usually seen in the tropical areas. In this you will get a history of recurrent fever with chills and rigors. Recurrent fever which is simulating malaria. This is usually seen, that's why I am saying that it's usually seen in tropical areas. The spleen is enlarged, and the exact genesis of portal hypertension because of tropical splenomegaly syndrome is not known. But in hepatic sinusoids and pre-sinusoidal area, in these cases there is infiltration of lymphocytes, massive infiltration of lymphocytes, and IgM levels are increased. So this is usually seen in this area, and usually these cases are malaria positive. Many a times they are malaria positive. So again, this exact genesis is not known, but usually in these cases malaria is positive. So somehow it is related to malarial fever. Then another variety of portal hypertension, of intrahepatic portal hypertension, is sinusoidal variety of portal hypertension. And this variety of portal hypertension, in which sinusoidal part of portal system is affected, intrahepatic part is affected, that is seen in cirrhosis. Usually in cirrhosis, any type of cirrhosis, whether it is because of alcohol, it is because of virus, it is because of connective tissue disorders, it is because of metabolic disorders, or if it is idiopathic. In any type of cirrhosis, there is involvement of the sinusoids, sinusoidal pressure is increased, there is obstruction of sinusoids because of the surrounding fibrosis, and this leads to intrahepatic variety of portal hypertension. Another entity is known as non-alcoholic cirrhotic nodules. Non-cirrhotic nodules, non-alcoholic cirrhotic nodules, non-cirrhotic nodules. In these non-cirrhotic nodules, the normal hepatocytes, they multiply and they form multiple nodules. These multiple nodules, these are because of regeneration of hepatocytes. They form nodules, and these nodules, they compress the portal system, the portal sinusoids, sinusoidal part of the portal vein, portal system, and because of this portal pressure is increased. Another variety is partial nodular transformation. One is non-nodular, non-cirrhotic nodular transformation. Another one is partial nodular transformation, in which the amount of nodules formed because of regeneration are In comparison to non-nodular, they are less in quantity, but still it produces portal hypertension. Similarly, focal nodular hyperplasia, this is another variety. There is only focal nodular hyperplasia. Regeneration is focal. In non-nodular, in non-cirrhotic nodules, it is generalized. In partial nodular transformation, again it is generalized, but quantity is less, amount is less. While in nodular, focal nodular, there is focal regeneration and formation of nodules, and these focal nodule can compress the sinusoidal area and it may cause portal hypertension. One condition is known as Budd-Chiari syndrome. This is hepatic vein thrombosis. Now, in this hepatic vein thrombosis, sometimes the thrombosis may extend up to this intrahepatic area of sinusoids and it can produce portal hypertension. Now again, presentation will be the same. Patient will present with upper GI bleeding, sometimes occult bleeding, and these patients, they develop anemia and can only be detected with the help of examination of stool. So these are the various varieties of portal hypertension, and this is how you will treat these patients. Now in my next class I will talk about in details management or further management of portal hypertension. Thank you.